Thank you to each of you. It's very nice to see some faces that I recognize, some friends, some people that I learned from yesterday. Thank you for coming. Thank you to these amazing organizations that have helped to coordinate this event and to support this. And thank you to Forward Alliance for the important work that you do to help prepare people. I appreciate you. You heard a little bit about my introduction, so I won't continue to tell you my story too much. But I became an EMT in 1994, which maybe tells you a little bit about how old I am. And I became an EMT because I was very interested in wilderness rescue and outdoor rescue and outdoor therapy programs. And so EMT was the easiest way to become a wilderness EMT back then. And as it turned out, and as life twists and turns in the way that it does, I found myself in between jobs, and the first job that I could find was on an ambulance. And being an EMT on an ambulance can be very rewarding. It can also really inspire you to be better, particularly when you see the paramedics and all the cool things that they're doing. So I paid for paramedic school. I became a paramedic in 1997. And during all that time, I was still working outdoor adventure, outdoor therapy, extended programs. And I was a firefighter paramedic for about 8 years before I moved to Alaska and became a flight paramedic above the Arctic Circle, and moved around Alaska a good bit. I started nursing school in 2006 and became a nurse in 2008. And since then, I've maintained dual licensure so that I can have my favorite things from each of the professions. I work as a flight nurse, and I'll show you my company here. Well, actually, for this company, Airlift Northwest, I'm an EMS educator. I have the privilege of working with some amazing, amazing teams who also teach me, probably more than I teach them. I am a paramedic and volunteer EMS director for my hometown fire department. And just like it is in many small towns, I kind of do other things as they pop up. So sometimes I work at our small town clinic as an emergency nurse and wear a lot of different hats. So that's what I bring to this presentation. When I'm not doing all those things, these are the things that I like to do that make my soul happy. So the objectives, I just want to give you a brief orientation to the geographical challenges of Alaska and the challenges of providing medical care over that terrain. I'll talk a little bit about the history of civilian air medevac in Alaska. I'll describe the multiple air transportation options for patients that we have in Alaska. And that should maybe have a little qualifier on it that there's no way that I could talk about every single possible option in Alaska. So I've tried to focus on the things that are most common. And for anyone who may be watching this as a recording, please know that I did not leave out an entity intentionally. It was simply that I only had time to focus on some of the ones that I was personally more familiar with. We will take a moment to honor some tragedies in Alaska Air Medevac and reflect on the lessons that we've learned through those and see how we can avoid such mistakes, hopefully in the future. And we'll do that through the vision of crew resource management, which I will call CRM throughout this lecture. I'll provide examples of specialized equipment that we use in medical transport. Some of it will look very familiar to a hospital setting. Some of it will look very familiar to an ambulance setting, and some of it might not look familiar to either setting. And then we'll talk about our competencies and our qualifications. If you're thinking about things that you're really curious about that aren't in this list of objectives, please feel free to write down those questions because there'll be time for question and answer at the end. And I'll be happy to discuss things as best as I'm able, or if I don't know the answer, I actually really like researching things and giving answers later. So if I don't know the answer, you would actually make me very happy to give me a gift of something to research and look up, and then I can send you the answer by email. So one of the challenges in Alaska is distance. And I was actually pretty surprised to learn that this distance from northern to southern Taiwan, which would maybe take 7 hours to drive. Does that sound right? 4 hours to drive. Okay, well, that's pretty close. It's the same distance in kilometers, very close from Anchorage to Denali National Park. But maybe that's 3.5 hours because we don't have as much traffic there. So if you look at that small section of the state, there's a lot of the state left to cover. And not only is there a lot of state just in actual land mass, but there's significant mountain ranges and a lot of glaciers and ice fields and many, 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 many islands. And not many hospitals. This is a map of our registered hospitals in Alaska. Our population in the state is only about 600,000 people. Half of those people live in Anchorage. And so Anchorage has the most hospitals. That makes sense. But we have communities as small as 12 people. And those people have difficulty accessing a hospital. If they need to access a hospital from maybe one of their very small villages, then they would transport to the nearest hospital within their region. And if that hospital wasn't able to make their capabilities, then they would get transported to another major hospital. And then if that hospital in Anchorage wasn't able to meet their capabilities, particularly for neurosurgery is one of our greatest weaknesses, then they have to go 2,000 kilometers south to Seattle. And so not only are things far away and not very common, we don't have a lot of hospitals, there's really difficult terrain in between those places. So I pointed out on the map that some places are surrounded by ice fields and glaciers, and those are the kind of things we think about when we think about Alaska. But sometimes it's just frozen tundra or marshland that's difficult to access. For the majority of Alaska, there is no road system. So we don't have the option to help a patient in the ambulance and take them on ambulance to the hospital for the majority of the geography of the state. And so the only option is airplanes. Fortunately, in Alaska, we have the most airports and the most pilots and the most planes based on our population. So if you were to take a ratio of our population, we have the most airports, the most planes, and the most pilots, probably out of necessity. And Alaska is really great about engineering things where maybe other people wouldn't engineer things. Like, we will put a runway wherever we can put a runway. And some runways only exist in the winter when the land is frozen. And then when the land isn't frozen, we don't have that runway anymore. And some communities have more difficult access actually in the summer. Because Alaska is so dependent on air travel and it's such an ingrained part of the history, it was probably inevitable that air medical transport evolved from a civilian side. So here are some pictures from history. And it's interesting, when I was putting together this presentation, I sent out a request to some of my friends for them to tell me their stories about being transported by a situation like this, where maybe it was just nurses who chartered a local independent plane and took out the seats and put in a stretcher and provided care through moderate turbulence in the ice, in night, to get the person to the hospital. And the stories that came in were fairly common, because this was a very common practice until really about 35 years ago. So people of my generation, I talked to people who they gave birth in a plane, like this situation. People that are the generation older than me, that was the most common way that they could access a hospital, was simply because there was a nurse or somebody who had taken military first aid, who volunteered to get in a plane and go with them. The commercial airlines also are truly fantastic about this. So in the middle picture, we have Alaska Air. And it might be difficult to see in this picture, but this is an isolette, and there's an infant in there. And so here we have medical providers loading a critically injured or ill infant into a commercial 737 because that was the only resource available. And that was very common. Alaska Air has a history of configuring their planes so that the last rows could fold down and there was an emergency stretcher there. And that was what was normal until commercial services started to fill the need. And I just thought that this picture was really cool. So Alaska has a really great history of working together. Alaska has this beautiful combination of wanting to be very independent, wanting to be very strong, but also really helping each other out when it matters and being a very strong community. And I don't see that in very many places. And I think that because of that, our system is very strong. And it takes all of these different entities to make our air medical system work the way it does, because each one fills a special need. And I'll talk about each one of these. So I'll talk about local rescue teams. I'll talk a little bit about our industrial organizations, such as mining for elements, mining of the earth, and helicopter ski touring, which has anybody seen a video of helicopter skiing in Alaska? It's pretty popular. Civilian professional air medical transport, which might be privately owned or it might be hospital based. And then we have two primary military services in Alaska, the Coast Guard, which is actually Department of Defense, and the Army. And they provide specific services that the civilian services aren't able to provide. This hashtag here, neighbor helping neighbor, is our slogan for our EMS conferences and all of our EMS organizations, because that's how we truly feel we are in Alaska, that government medevac is a neighbor helping a civilian medevac team, and we all work together. So the first one that we'll talk about is local rescue team, and this is a case that I was involved in my hometown of Haines, Alaska. And this is, I won't say it's very common, but maybe it happens 1 or 2 times a year in a small organization where a patient will be injured in a place that's difficult to access by foot. And we will call the state police, and the state police will authorize use of a helicopter, and they will actually pay for the helicopter services. And then the local fire department or the local rescue organization, or in my case, the local paramedic, will go in the helicopter to get the patient. In this situation, we hiked in maybe 6 kilometers in and 900 meters up, where a patient had fallen down a waterfall and fractured her pelvis. And by the time we got in and got up there, we realized that there was no safe way to get her out because we didn't have enough personnel. And so they brought in a civilian helicopter. And when the civilian helicopter comes in to the side of the mountain, and it has all the seats in it, you have to know how to take the seats out, how to get the stretcher in there in a way that it's secure, how to position yourself so that you can take care of the patient. And for those of you who have experience with this, you know that the way that this patient is loaded is backwards from normal. And that's simply because of some of the equipment that they had in there that we couldn't move. In an ideal situation, because I was sitting right here, the patient's head would have been next to me so that I could monitor her airway. But she had never had any airway problems the entire time, and so we felt very safe doing this. After she was secured in the helicopter. We took her maybe 15 kilometers to an airport, transferred her to a civilian medevac service, and then flew her to a hospital. Another service that might bring a patient from the mountains down to an airport is either a commercial mining industry or a helicopter skiing. And these organizations are much more familiar with how to organize their helicopter so that it can have a stretcher in it or have multiple people in it, and they train pretty regularly. And we train together with them. This is one of the helicopters that's at a mining site by my town, and they're responsible for taking people off of platforms that are about 1,500 meters up on the mountain and projected out from the mountain, and they go in and take the patient up. Most recently, they transported a patient with a femur fracture and then brought them down to where the ambulance could meet them because they were first responders, and we had paramedic on the ambulance, and the paramedic could help stabilize the patient and take them the rest of the way to the clinic. Then the patient had to go from our small clinic to a hospital because our small clinic does not have a CT scanner. It does not have nighttime rooms for patients to stay in. It's really just a day clinic for primary care that happens to have really bad emergencies come through its door a lot. And so that's where the commercial services come in. And this is what I'll be talking about for the majority of this presentation. The commercial services that you see here represent the 4 largest services, in my opinion, in Alaska. This one is government above the Arctic Circle, North Slope. This is Guardian Flight, which probably has the most aircraft and the most stations in Alaska. And they have different aircraft at different stations depending on where they're going to be responding to. This is LifeMed Alaska, and as you can see, they have multiple different types of aircraft. They are the only entity that has a non-government helicopter, and they have 2 or 3 of them. So it's very rare that there's helicopters used in civilian medevac in Alaska because they simply can't cover the distance. So they're very effective to get someone out of the mountains or out of a remote location to somewhere else, but they just can't handle the distance that's required in our state. So we use mostly planes. And then this is my organization, Airlift Northwest. I worked for this company when I moved to Alaska above the Arctic Circle and have done mutual aid responses with all of them. And it's interesting because the management of the companies, sometimes they like to feel like there's competition between the companies. But those of us who actually work on the planes, the nurses and the paramedics, we all see each other as friends. And we all party together, and we all train together, and we all like change from the same company to the different company. And so we don't have that feeling of competition at the lower level, neighbor helping neighbor. These folks are amazing. These folks, the Coast Guard, they are the true heroes, in my opinion, of Alaska air transport. So they are under the Department of Defense, and there are multiple stations in Alaska, but the 2 larger ones are Air Station Kodiak and Air Station Sitka. And these pictures are from Air Station Sitka. And I have the privilege, which I take as a great honor and very humbly, of training with them every year. The rescue swimmers here that you see in this image, the rescue swimmers at the Sitka, Alaska base respond to more patient transports than any other station in the entire Coast Guard. Many, many stations in the entire Coast Guard in America respond to problems with boats that are taking on water, boats that have had accidents, boats that are maybe doing something illegal. But in Alaska, because our weather can be so bad so quickly, and because so many of our airports are not regulated by the Federal Aviation Administration for night approaches. Sometimes the only option to get a patient to a hospital is to use the rescue service of the Coast Guard. They fly with night vision goggles. They can fly in significant terrain and weather. They are incredibly specialized, and they are trained to almost exactly the same level as a Taiwan EMT-2. And so some of the doctors are probably thinking, and maybe some of the EMT-2s are probably thinking, wow, I wonder if some of those patients are more critical than what I would want to handle as an EMT-2, or than what an EMT-2 would handle. And that's an appropriate thought. And if the patient is more critical than what the rescue swimmers feel comfortable taking, then we go. I've flown in this helicopter 5 or 6 times accompanying a patient because the patient was on a ventilator or the patient was on vasoactive medications, and that was not in their scope. And then we just have to figure out how to get home a couple days later. The Coast Guard it's hard to see from this picture, but the Coast Guard is trained in pickups, so they can lower a rescue swimmer down, extract the patient, hoist them back into the helicopter, and they do that over the ocean, and they do that in incredibly dangerous situations, like in between the trees. And when something really significant happens, we all come together and we work under the same incident command system that I saw demonstrated at yesterday's disaster drill. So here, this picture is the runway in Ketchikan, Alaska. After 2 aircraft collided over the ocean, there were 11 patients that we knew of, so significant trauma, but also very interestingly, fuel contamination. Because when they swam away from the aircraft, they swam through the fuel of the aircraft. So, pardon me. So they had hazmat contamination plus 11 trauma, and then there were still at least 9 more people missing. And in this picture, we have the Coast Guard, C-130. That's amazing. And then the Coast Guard Sikorsky MH-60, which you saw in the other pictures. Civilian medevac Lear jets, there were 2 of them in there. And then right here is a King Air. All the different organizations working together under incident command. So what does it look like if someone wants to request an air medevac in Alaska? This is a simplified version of the process. If an organization decides that they have a patient that needs to be transported to a higher level of care, there's different pathways dependent on whether they are a clinic or whether it's an ambulance service. So if it's an ambulance service, if it's an EMT, they're automatically authorized for emergency extraction. And which means it doesn't have to go through a physician review. It's automatically approved. And once it's automatically approved for emergency extraction, then a dispatch center will contact the pilots of the civilian service, and they'll do a weather check. And the pilots will do a weather check only knowing the location of the patient and the weight of the patient. They never know the condition of the patient, and they never know the chief complaint of the patient. And that's done intentionally so that the pilots don't feel pressure to make a higher risk decision than what they might otherwise. Is there, maybe some weakness in that system? Probably. If they find out that the patient weighs 5 kilograms, could they feel more stress knowing that it's a child? Certainly. But the goal is for them to make their decisions based on safety and weather. And then once the pilots have decided that that the weather is okay, the flight will be approved and the medical crew will be activated. And then the medical crew goes through the same decision-making process. Is it safe to fly this patient right now? Some things that might be factors in whether or not it's safe to fly the patient right now are turbulence. If turbulence is forecast to be between moderate and severe, there are some situations that we will wait to fly, like spine fractures. We would wait to fly that until the weather gets better. Another situation that's very dangerous to fly in significant turbulence is preterm labor. So there might be a separate decision-making pathway there. If the request is coming from a clinic or a hospital, then the provider, which might be a nurse practitioner, it might be a physician, it might be a community health aide, they are responsible for contacting a hospital and a consultant and getting an approval to receive the patient. Sometimes that process can take many hours, especially when we had so many hospitals on divert during COVID. So sometimes the patient is waiting simply to find a hospital that's available and willing to receive the patient. And the challenge with that is that in many small communities, their airports are only accessible during daylight. And in winter, sometimes daylight is very short. So it's a very difficult task for the providers at the clinics to find an accepting physician, and it can be very stressful for them. Once they find an accepting consultant or hospital, then the pathway is the same. And that's what I do once I get activated. So most of the time, depending on how we were activated, whether it's an ambulance pickup or whether it's a clinic pickup, things are totally normal. We land at the airport and an ambulance meets us, and we go inside the ambulance and we assess the patient, we stabilize the patient, we put him in the plane, and that's easy. Sometimes we will go into a small clinic, and this is a picture of the clinic where I work in Haines, and it's very nice and clean and organized, but it doesn't have a lot of specialized equipment. So this portable X-ray machine is older than I am. It's really hard to work with. So if the patient needs a CT scan, they have to go to a hospital in Juneau, which is a flight. And if we just don't know if the patient is having a stroke or not, the patient has to take a flight to Juneau. So sometimes we'll go into the clinic and we'll work alongside them to help stabilize the patient, get patient report, and then we'll take the patient in the ambulance back to the plane. This is also pretty easy and normal. Sometimes things are not easy and normal. In this situation, but sometimes we're not using a normal ambulance. So we go to the clinic or we go to the site where the patient is, and we get the patient, and the local rescue team or local volunteer ambulance will help us. And then we have to get the patient back to the plane, and we are monitoring and providing care for the patient the whole time back to the plane. So we have to learn how to make the equipment that we have functional for the situation we're in. Think about something that we heard yesterday. The three aircraft that are the most common in civilian medevac in Alaska are the King Air, the Pilatus, and the Lear, and we'll talk about each one of those. So this is a Beechcraft Super King Air 200. For those of you that are familiar with aircraft, you know that King Air took the Super away from its name a couple decades ago, but because they are so hard to come by, we still have those models in Alaska. And those models are not actively made anymore, and it's very difficult to find repair parts for them. But a twin turboprop plane is really powerful for short takeoff and landing runways. And it has range. It has the fuel capacity to be able to do a 3 or 3.5 hour flight, depending on wind. And so it makes it a really capable aircraft. Unfortunately, it's just more and more difficult to maintain. Here you can see that there's some details about it. Its average speed is about 500 kilometers, but it is very susceptible to headwinds. So it might be slower than that. Village to hospital, depending on the proximity of the village to the hospital, might be anywhere from 15 minutes to 60. I think that my shortest transport time when I was working above the Arctic Circle was there was a village that was like 11 minutes away. And so that was the fastest. If we're going from a regional hospital to a central hospital, it tends to be about 2.5 hours. And if the patient has to go to the major trauma center, then it's about a 5-hour, and sometimes they have to stop for fuel to refuel with the patient on board. The runway requirements are really short, and it's often equipped with very soft tires, tundra tires, so that it can land on gravel runways, which makes it very versatile. And the position of the propellers and the wings and the tires makes it so that when this plane lands on gravel, it avoids putting the gravel into the propellers, which is very useful. This is the Pilatus PC-12. It's a single engine turboprop, and it's a plane that's made in Sweden. There's a few of these in the state. Our company has quite a few of them. Its average speed is about the same as a King Air. The advantages to the Pilatus are that it's currently made, so you can get parts for it. But also it has for those of you who like aviation and planes, it has a different yaw dampening system in it, which means that it handles turbulence better. And that is wonderful, because turbulence can be very hard on a patient if they can't move to adjust to the turbulence. So it doesn't make the turbulence non-existent, but it does make it a lot better. Takes it from maybe a 10 down to like a 6. The times are about the same as the Beechcraft for travel, and the runway requirements are about the same. This particular Pilatus has a unique loading system. There aren't many that are set up like this, but this can handle a large patient up to 300 kilograms. And it's safer to load them with this hoist elevation and swing system. Sometimes actually the limiting factor in transporting a patient that size is the EMS stretcher is only rated for about 200 or 225 kilograms. So we have to coordinate with the local ambulance to make sure that their stretcher is safe for the patient, and then we can get the patient into this aircraft. If a patient of that size requires going to the major trauma center, it's a 4.5-hour flight. But our other aircraft, the King Air and the Lear, they cannot take a patient that is generally above 125 kilograms. Simply because of the way that we load the patient into the aircraft, the patient is often too wide to clear the door and fit into the system. This is the best ride on a good day from a place with long runways. This is a Bombardier Learjet 45. It is fairly new, probably 2 years old. Its average speed is about 800 kilometers per hour, but I just want to brag a little bit that I was on this flight where we hit our max. Maybe somebody can do the math for me, but we hit 711 miles per hour ground speed because we had a big tailwind. And it's never happened again since then. But wow, that was a fast flight. We made it to the trauma center in 1 hour and 38 minutes. And it's normally a 2 hour and 25-minute flight. The flight back was a lot longer, but that's okay. The patient leg is the one that matters. The disadvantage to the jet is that it's very heavy. It has significant thrust, and it needs a very long and very well-maintained runway in order to land. So generally speaking, the Learjet only lands at the airport where Alaska Airlines can land their 737s. So it can only go to very specific communities. Sometimes what we'll do is we'll use smaller airplanes to bring the patient to a community with a larger runway and then transfer them into the jet if they need to go to the major trauma center. And that still saves about an hour and a half, even with the different approach in transferring the patients in between the aircraft. And of course, we have to do this in all kinds of weather. In a perfect world, our aircraft can stay inside of a hangar. But it doesn't always work out that way. So has anybody ever had a job where you had other duties as assigned? Yeah, we do a lot of shoveling snow in the winter, a lot. And we also travel in every airplane with a portable like pump sprayer of de-icing fluid and antifreeze fluid, so that after we brush off the wings, we can spray the pilot. I don't do it, the pilot does it. Can spray the wings with this de-icing fluid, and that gives us 5 minutes. We can take off in 5 minutes with that, assuming that it's not heavy freezing rain conditions. And because Alaska weather can change so quickly, and because the conditions can be so severe, it's inevitable that we're going to have accidents in our industry. And so I just want to take a moment to honor the people that we've lost in the last 4 years. And I'd like to discuss these accidents through a lens of gratitude for them, and also thinking about what we can learn so that these accidents are less likely to happen in the future. This is Pat Coyle. He was a pilot that I worked with for many years. He was the kind of guy that told a lot of really, really bad jokes, but we loved him. And pictured here with Pat is Stacy Morse. She was pregnant. Her daughter, when her daughter was to be born, would have been named Delta Ray, and not pictured in this is Margaret. And they went missing on approach into a small island community in January of 2019. They just went off the radar. And the ambulance that was waiting to meet them, to bring the patient to them, or to bring them to the patient, I'm not quite sure which one it is, saw them on approach, and then they didn't land. And the ambulance was actually the one that activated the emergency system. They searched and searched and searched, and they found the wreckage of the plane 150 meters under the ocean 4 months later. They still don't know what caused the accident. The black box recorder was not working. All they know is that the 2 medical crew had undone their seatbelts in the last moments, and they're not sure why. This accident was a different company, and they accepted a flight that 2 other medevac companies had declined due to bad weather. And I'll talk about the lessons that we learned from that in a second. But they accepted a flight that 2 other companies had declined due to bad weather, and they flew into significant low visibility, hit a mountain, and we see the nurse Rob, the pilot Maddox, the paramedic Maddox, and the pilot Glenn, who died in this accident. And the resulting lessons from this particular situation was education to the requesting facilities. So the facility that called didn't understand that if one service said the weather was not safe, that they should wait until the weather gets better. And assuming positive intent, which we always do, they probably thought that since this team was coming from a different area, that maybe the weather was better in their area, but that remains to be seen. And so what we've learned from that is that if a medevac provider has a request for a flight and they turn down the request based on bad weather, it is their responsibility to call the other major companies and tell them, we just got a request, we turned it down for bad weather, we think it's not safe. So we share that information very openly, and that decreases a feeling of competition, it increases safety, and it reassures the facility with the patient that we're going to wait until something is safer. The exceptionally Another sad part of the situation is that this happened on a Friday night. The patient was stable through Friday night and was transported Saturday morning when the weather improved. So sad lesson. This is an accident that happened over here in a different part of the state, and everyone survived. They used their water egress training to be able to evacuate this aircraft when it went off the end of the runway. And the attributed factors for this accident were that the pilot took off with a tailwind and with a load that was not balanced. It's very important in airplanes to have weight centered appropriately over the fuel and the wings, and then considering where the propellers are. And pilots know a lot more about that than I do, to be honest. But also, it's very important that they take off in a manner that the wind lifts them up. In this situation, they took off in a manner that the wind pushed them down. This was a reminder to stop, use checklists, have a timeout, and kind of start over with thinking and to listen to other members. And this is where we can start talking about crew resource management. Some of you are maybe familiar with crew resource management. For some of you, this might be the first time you've heard about it. Crew resource management has been present in the aviation industry in the United States and in many other countries since 1977, so it's almost as old as I am. And the history there is there were two major events. The one that gets the most attention are two Boeing 747 jets that were in Tenerife, and it was very cloudy, and it was very crowded because there was a terrorist threat in a neighboring airport. And because there was a terrorist threat in the neighboring airport, all that traffic from the neighboring airport had to come to Tenerife. And Tenerife was not used to all of this activity. And it is notoriously cloudy weather there. So it was very difficult fog. And two airports collided on a taxiway. Or two aircraft collided on a taxiway. And in that, 248 people on one plane died, and 335 people in the other plane died. And what they learned when they listened to the recording of the cockpit discussions is that the second in command pilot had been making suggestions to the pilot in command. And the tower, the control tower, had been making suggestions to the pilot in command. And the pilot in command did not listen to those suggestions. And the aviation industry, kind of like some parts of medicine, it was determined that the pilot in command was the ultimate authority. And people were scared to speak up to him. And sometimes he was afraid to be wrong, which made them want to be more determined in their answers. So the response from the aviation industry is that they needed to figure out how to empower people to speak up, but also how to require that people in leadership listen. And that those two things come together to help maybe change a decision and prevent accidents. The components of crew resource management that we'll talk about are situational awareness, speaking up, accepting information, using checklists, cognitive offloading, which means using your resources, leadership. I took this picture of my flight partner dealing with an incredibly sick patient. This patient was in septic shock from COVID with a critical upper GI bleed. Wow. There was a lot going on. And in this situation, you can see in this picture that she's actually trying to take care of one of the IV lines. We have a pilot here who's trying to get the level of the stretcher down so that we can load the patient. We have EMTs who are working on seat belts, and we have somebody here holding our very expensive cardiac monitor, which loves to fall to the ground. And then this person is handling our ventilator. So everybody has a very important task. And whose job is it to have the awareness of the whole picture? It's everybody's. Who's the leader in this situation? The leader in this situation was my partner. Sometimes the leader in the situation is the pilot, but we make it very clear who's in charge. But we have trust and mutual respect and expectations with the ambulance organizations that we work with and with our pilots, that the situational awareness is a responsibility of everybody. So if something is not right, we expect you to say something. And if you say something, we expect that the leader is going to listen to that and address it in a way that is respectful and with eye contact. We have people with 3 different backgrounds, 3 different cultures working to take care of a patient. And this represents what we do. In this list here, you see the different organizations that we might be working with to help take care of a patient, any of us in this room. And they have different strengths, they have different cultures, and they have different ways of communicating with each other. Here in the emergency department or in a traditional ambulance, we have set protocols. We know our environment really well. Once we get the patient into the ambulance, at least, it's always the same in the ambulance. And we know our coworkers very closely. Here in rural EMS or in rescue agencies, we might have protocols and we might have teams that train together, but the environment is incredibly different. And then in this last column, maybe we know some of the people we're working with, maybe the infrastructure has been devastated. Maybe we have to make up some of our own infrastructure and create our environment. And why do I bring this slide up here? It's because we need to learn how to communicate in all of these different situations in ways that are safe and effective. And I think, my opinion, is that it's almost impossible for a leader to have a complete understanding of everything that's going on in that situation without input from other people. And so, of course, the input is important, but the other thing that's so important is receiving that input and integrating it into the entire picture. So one of the things that was addressed in crew resource management was how to speak up. And there were universal words that have been integrated into this that required attention from the leader. Some of these we're pretty familiar with. Stop, wait, not ready. Those things are pretty universal. But in a hospital setting, for some reason, it wasn't working as well. And so hospitals have adapted a different framework. And the framework that hospitals have adapted is for the person to say, I am concerned. Or if it's something more serious, I think this is a safety issue. And then this is the most powerful if it is supported by a resource. For example, I am concerned that this patient's pulse oximetry is 86%. That's pretty concerning. So imagine that the doctor or the nurse says, no, it's okay. But then if you were to come back and say, I think it's unsafe that this patient's pulse oximeter is 86%, and our protocols say that we should give them oxygen, then that is a requirement for a conversation. And in wilderness medicine and in our flight team, we call that a huddle, which is a phrase taken from American football, where we all get together, we talk about what happened, and what we need to do. And sometimes that takes 15 seconds. Doesn't need to take a very long time. And having permission to do that is one of the most important components of what we call just culture. Just culture is also called safety culture. And this is a proper name for a concept that applies to high reliability organizations, or organizations that perform in dramatic environments and are expected to perform as experts no matter the conditions. So in order for them to be able to do their job competently and as a team, this is encouraged by hospital culture, aviation culture, and aeromedical culture to have the framework set up for this. And what this created was that it was no longer okay to blame someone. It took away blame. Just culture means that if I am a manager of an aeromedical team and our flight team does something that I don't understand, or I question, or I think maybe it wasn't the right decision, the first thing that I think is I trust that they were doing the best thing they knew how to do at the time based on the information they had and the situation they were in. And so instead of blaming them for doing the wrong thing, you instead look at this as curious. What was going on? What was their situation? I believe that they were doing the best thing they knew how to do at the time, because I'm going to attribute positivity to this. And I'm going to learn instead of blaming. The other part that's super important about just culture, or also called safety culture, is to try and set people up for success. And this is something that requires great humility on the side of leadership. Something that I have learned as a trainer of new flight nurses and in curriculum development is that sometimes when I make something to help someone, they don't understand it the way that I intended it for it to be used. And that can be challenging to some people's egos. But if you genuinely want the other person to succeed, then the appropriate path is to ask, what would make you feel more supported? What would give you what you need so that you feel safe and you feel like you have structure and you have the resources you need so that you can do your best job? Part of that is in protocols. Part of that is in permission to speak up. Part of that is in training together with your team. Another thing that makes people feel very reassured and limits the opportunity to forget something are checklists. Pilots have a lot of checklists. Maybe I have a short attention span. It's probably the paramedic side of me, but the long checklists that the pilots use, sometimes I get impatient with them. And what we've learned in flight medicine is that we do better with shorter checklists. But boy, do we love our checklists, as long as they're short. And if they're short, it makes us feel safe. It's like having someone give us a double check. And it's also kind of this way to put yourself in the same mindset and to forget everything that happened before. And you know that you're going to start your routine the same way every time. And that is really valuable. The checklists that we see here, this is a military checklist to determine whether or not a mission is safe to accept based on operational safetiness and readiness. This one is from a rope rescue book about informing team members and communicating important information. And this is one, do I need to slow down? No, okay. And this is one that we use before, after the door closes on the aircraft and before every time we move the aircraft. And like a pilot checklist, there's a call and there's a response, and it's very structured so that the pilots can recognize very quickly if we say something unusual, they know we have to stop and investigate it. If they hear something that's normal, then we can go on to the next item. And I can't tell you enough how much this sets the tone. All the joking that was happening before we got in the plane to go accept the mission, or any stress that maybe we felt, once the door closes and we do this checklist, we are on task as a team. And it really unifies us, which I didn't appreciate at first. But now I see that it's very valuable, and it's safety. We check for hazards. We check the patient litter. We check that our equipment is recovered and secured. The door is locked. Seatbelts are on and fastened. We call this OLEDs, which doesn't mean anything. It's just the first letter of each word. But we had an event less than a month ago that we call an OLED success. We were on a runway and we had the patient on board. We were getting ready to take off for the hospital, and I was on this crew, and the pilot called outside, and normally we would say clear left, clear right. That's normal. In this situation, the pilot called outside, and I said aircraft on the left, 9 o'clock. He couldn't see it because of the approach and because of some other obstructions. That aircraft not only came in very close on our left, it taxied so that its wing was over our propeller. If we would have taxied forward at that time, we would have had a collision. But that was an OLED's win. And that's something that we debriefed afterwards, and in the value of that. I talked a little bit about huddles, which is an American word, and you don't have to use it, but you can if you like. But another way to think of this might be a deliberate practice pause. For those of you in the hospital, you're probably used to having a timeout before a high-risk procedure. Does that sound familiar? Timeout? Yeah. And sometimes it's timeout for patient report. Sometimes it's timeout to confirm that we're going to perform a procedure on the correct person and confirm that it's the right side of the body. But it's a deliberate practice pause. And we engage in these at these critical points and any other time that someone wants to ask for one. So anytime we transfer care, because transfer of care and patient handoff reports are the greatest source of medical errors. So we are very intentional to make sure that we have a safe and effective transfer of care report and there's no distractions. And we literally say, time out for patient report. Is everyone here that needs to be here? And if they say no, we wait. And then we give a report, and our report with, are there any other questions for us, will be available if they come up. After we have completed a task, for example, after we've secured the airway in the patient, we'll say something like, intubation confirmed, 22 centimeters at the teeth. So we've just done a quick recap, took seconds to communicate the information. Anytime there's a change in condition or a change of circumstances, we'll regroup. And I probably ask for these pauses more often than my peers. If the patient suddenly deteriorates, I'll ask for my partner to step back with me, and we'll just evaluate, starting with airway, ventilation rate, what's our mean arterial pressure, how can we optimize the blood pressure, how can we optimize these things, what are we forgetting? And sometimes my partner has found information that I didn't know about yet, or vice versa, and then putting ourselves together, we can solve that. And honestly, I don't think any one of those has ever taken more than a minute, and it's really useful. And then in our company, we double check all medications, not just high alert medications, because we work in the dark, we work in high stress environments, We work in moving environments. And increasingly, medication vials look very similar. Just the other day, there was a vial of lorazepam, and the color on the label and the size of the vial was the same as the color of the label and the size of the vial as morphine. They looked exactly the same. And in the dark, if somebody's thumb was over the name, maybe it would be easy to make a mistake. So on our team, we double check every medication every time. And that might be that I show my partner the vial and I say, I'm going to give 50 micrograms of fentanyl. And they look at it and they say, okay, I see 100 micrograms in 2 milliliters, so you're going to give 1 milliliter. 1 milliliter. Every med, every time. And I can't tell you how many times that has been a good safety check in our career. I would like to think that I didn't need that, but I do. And I'd rather do the safest thing for the patient than think that I'm better than that. And double checking our protocols. So we are very encouraged to make a plan for every patient on the way to the patient with our partner. And this is something that we do to help each other learn, and it's something that we do to help prepare for the situation that we're about to see with the patient. So as we're going to every mission, we talk about what it could be. We get our protocols off of our application on the phone. They're right there. And we say, okay, so it's probably sepsis. We're going to do this. We're going to look at this. We're going to consider this for our mean arterial pressure. If the patient needs intubated, that we have the patient's weight, we're going to use this dose of rocuronium. We're going to use this dose. And we plan all that ahead of time. And so if things deteriorate, we already have that all figured out. And the other value of this is that while we're planning for the worst case scenario, we're helping each other learn, and we're doing the same thing that athletes do when they are rehearsing their routine. We're doing the same thing that visualization, the same technique that athletes do when they're rehearsing their routine. Have you seen Olympic athletes, mostly skiers, before they do their performance, and they'll be practicing before they go down? Research has shown that if you visualize yourself being successful doing something and you know what successful looks like, then it trains your brain in almost the same way as doing it. So when we're having these conversations with each other and we're thinking that if we're going to intubate, we're going to use this medication, it helps our brain learn that even if we don't do it. And the other thing that it does that's so valuable, particularly to our younger flight team members or our newer flight team members, is that it helps them build a foundation for judgment. Because if they hear somebody with more experience say things like, oh, and if this turns into shock, we're going to use norepinephrine, then they have that in the future. That's something that they can learn from if they see that in the future. So we're helping by role modeling, we're helping them build a foundation for judgment in the future just by talking out loud about the things that could happen on the case before we get there. The other value of that is that now my partner knows what I'm worried about, and I know what my partner's worried about. And if I see that, I can tell them it's happening. And so we have that same model in our head or the same map in our brain so that we can help each other be alert to that. If at any point we're like, ooh, I don't think our protocol fits this situation, and we have to defer away from our protocol, then we explain that to each other before we do it, whenever possible. So an example might be, I know that our protocol says that we are okay because the patient's mean arterial pressure is 65, but his mental status is very poor, and so I think we should support his blood pressure even more right now, even though our protocol doesn't say that. And we're really fortunate that if our answer isn't in our protocols, we can call a doctor very quickly and ask for help. So we are accredited by this organization. And if you'd like to learn more about the organization, there's a QR code there for you. CAMTS is the Commission on Accreditation of Medical Transport Systems. We call it CAMES, which is maybe how that would sound if it was a word. I'm not quite sure. But CAMES is an external agency that has created standards and evaluates teams every 2 or 3 years, depending on the team. And they send people out to evaluate the site of the medical air evacuation company to make sure that they're meeting the standards. And if they don't meet the standards, they generally, if it's not super significant, they generally have time to repair that within a certain amount of months, and then they can get reevaluated. And having this accreditation means that you are meeting the industry standards for safety. And the list of what they evaluate was very, very, very long. So I did not put a picture of it on this slide, but there's a short list here about management processes, management quality, patient care policies and credentialing, how our nurses and paramedics get oriented and continuous training, our infection control and communications. And if you follow the link, you can access their specific items through their website for free. Some of the things that they require include what equipment we carry, but we also include many things that are not required because of how long our transports might be. So these are some pictures of our kits. This is our pediatric and infant airway kit, and we keep that separate from our adult airway kit. Again, it just kind of helps our brain be into that space of taking care of a pediatric patient. This is our primary bag. It's about as big as me, and it weighs 15 kilograms. And in this bag, the goal is if you had to grab one bag to manage a patient for 10 minutes, what is everything you need in that bag? So this has intubation, emergency medications for cardiac arrest, emergency medications for airway management, cricothyrotomy, needle decompression, those types of things are there. And then in the other bag, this is our medication bag. And our medication bag probably has maybe 75 different medicines in it. And some of them are pre-mixed into IV bags, but you can imagine that if we carried many things pre-mixed in an IV bag, it would be very heavy. So most things are in vials, and we get to act like pharmacists and mix our own medications a lot. And that's one of the most valuable times to have a double check, because not only could I grab the wrong medication, but maybe the IV solution that I'm selecting to mix it into isn't compatible. So if I'm mixing a norepinephrine drip, maybe that's not the best example because it can mix in both things, but if I'm mixing something that does well in normal saline but does not do well in dextrose 5%, then I want to double check that with my partner. Every medication, every time. And we check these for expiration every month, and it takes hours and hours. But it's also a good way to stay familiar with what's in your kit. Some of the common themes of the medications that we carry a lot of vasopressors. We carry quite a few antibiotics because we pick up patients from small clinics that may not have antibiotics. So that's unusual for a flight team to carry as many antibiotics as we do. We carry a lot of cardiac medications and infusions, and some medications for obstetric complications. We carry some things with redundancy, but also for clinician preference. So we have a video laryngoscope, which is pretty standard, and we train with it regularly, but we also still carry direct laryngoscopy because for those of you experienced with airway management, you know that sometimes it's easier to use, particularly if the airway is very contaminated. And our company prefers that we use video laryngoscopy as a first choice, but if our clinical impression is that the patient would be safer to intubate with direct laryngoscopy, they support us in that. We have a bougie, we train with the bougie, we train with direct laryngoscopy, and every year we go to the operating room at our major trauma center and we perform supervised intubations on patients with an anesthesiologist. So we do that for annual intubation training, and then we also do mannequin training of all ages. This is some of the specialized equipment that we carry. Because our transports are so long, we avoid spine boards. So we have vacuum mattresses, which once we get to altitude, the pressure releases and they become weak again. So we have to use the vacuum again to retighten them, but that's okay. We just know that we have to do that. And also our stretcher in our plane is surprisingly not comfortable. So the patient is often more comfortable in the vacuum mattress. And maybe we use the vacuum mattress for pelvis trauma, femur trauma, spine trauma, but we also use the vacuum mattress for every patient that is intubated to help keep the airway secure and limit movement while we're putting the patient in and out of the plane. And it's better for their skin perfusion over long transport. This is one of our partners, Diana, and you can see that everything is pretty close at hand. This is our ventilator, which is a Hamilton T1. Some folks are probably familiar with Hamilton ventilators. This is their transport version. It's impressively capable. It can do CPAP, BiPAP, pressure ventilation, volume regulation, sensing regulation. It can do neonatal ventilation, and it's very, very capable machine. We have our IV pumps here, which are pretty standard. Our greatest challenge with these is that if they hit the ground, they explode into like 100 pieces. So it's very difficult for us to keep them secure, and we're always trying to improve that. This LifePak monitor probably looks pretty familiar to folks. There are other options out there that are lighter and maybe easier to use, but what we've learned is that in Alaska, when it's cold or when it's wet, this is the most reliable for us. How many of you have tried to use a touch screen on your phone in the rain? It doesn't work very well. So unfortunately, the same problem happens with cardiac monitors. And then I wanted to point this out because not a lot of flight teams are doing this, and I think it's pretty impressive that some of us are. Our ventilator can be adapted to carry epoprostenol, which we learned about during the COVID pandemic, and it's a pulmonary vasodilator. So it's pretty significant that we can carry that, and it requires specialized equipment and provide that service for patients. So that's a lot of things to keep track of. There are certain qualifications that are expected to be hired into a commercial flight team. Generally speaking, for a nurse, they expect that you have 5 years for my company, 3 years for other companies of critical care experience, and that might be certified emergency nurse or critical care registered nurse. And then for paramedics, maybe The person had critical care paramedic certification going in, and of course ACLS, PALS, BLS. Those are required to apply. Once somebody gets hired, then the organization has the responsibility to provide training to the new flight member. And so the aeromedical team will provide initial orientation from the company. Sometimes it's 2 weeks, sometimes it's 3 weeks. It's very intense. And then maybe they'll get advanced trauma life support training or equivalent. There's a class that's specialized just for aeromedical providers for advanced trauma care, neonatal resuscitation provider. And then generally speaking, within a year, we have to take one of these accreditation tests. So for a paramedic, they might take a test to become flight paramedic certified. It's incredibly difficult. And then for a nurse, we take a test for certified flight nurse. And it's also difficult, but I secretly think that the paramedic test is actually harder. I don't think any nurse would want to hear me say that. And then a lot of us also take advanced burn life support, but that's not required. And then, of course, we have to keep those renewed every 2 years or however long they expire. In addition to our certifications, we have to maintain ongoing competencies because we respond to a lot of situations that are critical but low frequency. And what research has shown is that even with CPR training, proficiency starts to decline after 90 days. So if that's the case with CPR training, what about neonatal airway management? So we train at least every 90 days on events that are critical but not common. In addition to that, I told you that we go to the operating room for our intubation experience every year. We have to document a certain amount of airway practice on mannequins, both intubation and supraglottic, which is our backup. And we have to do specialized device training every year on different cardiac devices. Balloon pumps, transvenous pacers, Impella, ECMO. And please feel reassured that if we're transporting an ECMO patient, we're taking a perfusionist with us. That is not my area of expertise. My job is to provide the flight medicine component. We do specialized pediatric training every year. And then every 6 months, a team will come to our base and we do scenario assessments. I told you that we're flying patients on ECMO. This is a training session to fly a patient on ECMO, which is not something that we did before the COVID-19 pandemic. But during the COVID-19 pandemic, we started to fly patients prone, which was weird, and on ECMO, which made everybody nervous. And now it's like what you do on Tuesday. It's normal. But we do take other experts. Oh, wait, this person. We do take other experts with us when we have to transport a patient who's on ECMO or who's getting transported to prepare for ECMO, which can be very crowded in a small plane. So when we're training, we don't just talk about what it would look like. We actually put all the equipment, all the people in the plane, take off in the plane, land in the plane, so that we can see how all of the things work together in the actual environment. And we debrief a lot. We actually actively seek feedback, and we actively reconnect after every mission, every time. So every mission, every time, we call the facility or the ambulance that we picked up the patient from, and we tell them how the patient did in flight. And that kind of feedback is very rewarding to a lot of those organizations that sent the patient out, because they're often curious, how did the patient do? Did I do the right thing for the patient? Did they make it better to the hospital? And so they really value that connection, and sometimes they learn from that as well. We have to call our dispatch every time and ask, is there anything to debrief from this flight? Because sometimes maybe the ambulance was late or maybe the weather changed. And so we just want to talk about if there's anything to learn from that. We debrief with each other, generally right after we transfer care of the patient between the two partners. And, we like to do the kind of standard approach of like, I think this went well. I think we could have done this better. And then my question for everyone I work with, I ask them, how could I have been a better partner to you? What could I have done to make you feel safe and supported? And I've learned a lot from that, and I think it's made me better. And then we debrief with our pilots. Sometimes the pilots don't understand why we did something we did, or they did something that we didn't understand because they got rerouted through the flight pattern. And so this is the time to communicate that. And one of the most important things is that if something happens that's unusual during the patient transport, we trust that they're doing the best thing they knew how to do at the time. And we'll figure out the details later. But I know that they're doing something weird for a reason, and I trust them. And so we think that about the pilots, and the pilots think that about us. And then each one of our patient care charts is reviewed by a peer organization of other flight nurses within our company. And quality assurance goes to each of our medical directors. So every chart, every time, which you might think would be intimidating. And at the beginning, it was pretty intimidating. But this is what makes it not intimidating. This is our primary medical director, and this is our associate medical director, and this is our pediatric medical director. We have 3. That's pretty cool. They're all emergency department attendings at the Major Trauma Center, and she is also an emergency department attending at a children's hospital. So she is an attending at 2 hospitals. And obviously, we train together, and we hang out together, and we go fishing together. And they fly with us as partners regularly. So sometimes I'll show up to work, and Dr. Uternachi will be my flight partner. And it doesn't mean I'm in trouble. It means that I have an awesome flight partner for the day. And we have a really good time together. And because we know each other so well, there's deep trust. And they know that if I did something that wasn't the best idea, that there was probably a good reason for it. And so they know to call and ask. And I know that when I get a red flag on one of my charts from one of the doctors, I know that they're not going to get me in trouble. I know that they are going to teach me something. So when I used to see this, that one of my charts got flagged for an error, I used to get this sinking feeling in my stomach, and I would hurry to my computer, and I was very anxious. And it never turned out to be anything that was said with blame. It was always something to teach me. So now when I see this, I think, oh, cool. What am I going to learn? And that culture is very important. Another quality assurance metric that they monitor is that each of our intubations, if it's done on the video laryngoscope, is recorded. There's a USB flash drive, and we take that USB flash drive after our intubation, and it goes into an envelope, and it goes somewhere magical to our medical directors, and they watch it. And then at our quarterly trainings, we watch videos of difficult cases as a large group, and our doctors talk about things that can help us be successful for future difficult cases. They are also evaluating each of our charts for these metrics. And GAMET stands for Ground and Air Medical Quality and Transport. And it's an external company that can help track data from all of your charts to see how your organization is doing with preventing the patient from getting cold, appropriate treatments for altered mental status, appropriate management of hemorrhagic shock, blood product administration, TXA use, things like this. And our company follows this. If you'd like to learn more about it, the QR code is there. And with that, I'd really like to thank all of my teachers and my students who have taught me over the years. This is my contact information. And I'm happy to take any questions. Thank you so much.